Hi everybody, I make it 2 o'clock, so I think it's time to get underway. Thank you for joining the Primary Care Direct Premises Policy Review webinar. We've got 30 minutes to pack in a lot of information. However, please do use the Q&A facility, which you should find within the Zoom screen, to ask any questions you have. We'll hopefully have time at the end to address a few. However, we do have your email addresses as well, and you'll get our contact details, and we'll hope to send out a review sheet afterwards. I'll hand over now straight away to Lisa Aguirre. She's a partner at Capstick Solicitors, and she'll reflect on the key elements from the Premises Policy Review. Thank you.
Thank you, Damien. And hello to everybody. Thank you very much for dialing in and joining today's webinar. So as Damien said, I'm a partner at Capsticks. Capsticks is a law firm that specialises in advising the health and social care sector, all its legal requirements. I'm a property lawyer by specialism, and I spend about 50% of my time advising GPs on all their property requirements. So I'm delighted to have the opportunity to talk to you about the GP Premises Policy Review today. So I think actually the main part of this session will probably take about 25 minutes, and there'll be 5 minutes maybe for catch up. If we do run out of time for any questions, and as Damien said, I'm very happy to follow those up directly with you afterwards, either on a phone call or via email. I'm very aware that probably the people who've dialed into this call have got some property concerns or questions that they'd like to get some answers on, so very happy to help. So the first slide really talks about the background to the policy review that came out a few months ago. So there have been lots of reviews over the last 2 or 3 years in the healthcare sector. And so I think really the main precursor to this was the Naylor Review in 2017 that made some quite controversial comments about how NHS funding should be applied towards improvement of primary care, putting quite a lot of pressure on the system. I know we had the announcement of the injection of funds through the ETTF, which I'll come on to, but basically I think it was saying that, you know, we need to be moving into better premises, probably bigger practices need to be coming together, but there needs to be a little bit more robust governance and demonstration of almost a business case potentially for getting your funding for your premises. And then we had the GP Partnership Review, was really looking at the model of partnership going forward into the future for primary care, and whether or not that was the right model or not, and how that perhaps impacted on issues like property. We then in January saw the NHS long-term plan, the introduction of the 5-year framework for the GP contract reform, and then a few months ago the GMS contract settlement. And then the big announcement, with not very much time to spare, for primary care networks. I'm sure many of you who are in practice will have spent most of May and June working up your network agreements and deciding who you were going to jump into bed with for the 1st of July, with the idea that over the next 2 years, primary care networks will work very closely with the FTPs to work together to become part of the integrated care systems, with the emphasis on aligning and integrating primary care with other healthcare systems. We then had the GPC England's Premises Survey in 2018, and then the GP Premises Policy Review in June 2019. And last week we heard about the Spending Review, which in a number of areas in the policy review mentioned that the outcomes and the implementation going forward of some of the recommendations in the policy review would depend on the amount of airtime GP property received in the spending review, and I'll touch on that a little bit later. So that's just a bit of policy background. Primary care networks, this slide really just sets out some of the key points, but the main thing today is to talk about the implications for the primary care estate. So as you will all know and will have heard, on numerous occasions over the last few months, primary care networks are seen as being a major investment in primary care through the new DES contract. There's going to be a lot more money in the system, but it's going to be available, the enhanced services contract, through primary care networks, not at practice level. So What else does this mean? It means that the workforce is going to expand. There are many new funded roles that are going to be required. So with extra people comes the need for extra space, which may mean that you might need to alter the footprint of your existing property, or may mean actually you might need to think about moving to new properties. That, in addition to practices within a network being told that they need to work more closely together, does that mean you need to think about sharing property and joining forces to perhaps move to a new building? In addition, one of the third things around primary care networks is digital reform, and what impact is that going to have on the sort of property you might need to use, and again, how you're going to use the space within your property. So there's a lot to take in, and it's really worth thinking very carefully about what the implications are going to be for the primary care estate. Is the or your current model fit for purpose? And what are the main issues? The next two slides really talk about the common issues I see day in, day out. Me and my team, when we get contacted by GPs and practice managers asking for some legal advice around property. And these are the most common issues we're seeing at the moment. A frustration with the inability to fund refurbishment or redevelopment of existing premises. I know that I've had a few, there've been a few requests for sort of some answers around that. How can it be done within the existing system where there is a limit on the amount that can be released through the premises cost directions, and some issues with moratoriums being putting on the ETCS fund. The inability to move from unfit premises to fit for purpose surgeries or multi-let health hubs. One reason being there may be stalemate because your existing property may have individual partner investments in that, the partners are relying on that for perhaps the pension part, but the value of that property is aligned to use for primary care. So moving to a new property, that estate, that building will become surplus if it doesn't have a viable alternative use value to allow the investors to release the investment they expect, and nobody will agree to sell. Then how are you going to then move on into the future? And then in addition to that, how you actually work with other practices or a developer to be able to fund moving into new property. There are succession issues with owned premises. We see that quite a bit, where new GPs coming through perhaps don't want to invest in freehold. They don't have the money, or they don't have the feeling that they want to commit, like it used to be in the old days, to investing in capital, and therefore that might put them off joining your premises. Even if you have a lease, which in some ways can be seen to be a more flexible arrangement to enable succession, there might be issues with new partners being worried about signing up for a lease for a certain length of time, especially where perhaps they're coming in as a young partner and the rest of the partners are going to be retiring in a few years, and their concern might be about being the last person named on the lease, the last man standing issue. Sometimes sale and leaseback can work really well. You sell to somebody and you get a more flexible arrangement. You hand over your ownership, but you also hand over your responsibility. But again, there can be issues there around the length of the lease that you're being expected to sign. We see this a lot, a lack of regularised tenancy arrangements in place with GPs, leading to uncertainty and disputes. You probably have seen in the press a lot fairly recently, some news around NHS Property Services getting a little bit of bad press around their attempts to hike up some charges for GPs who've been on occupation properties without leases for a significant period of time. If you haven't got your house in order and the right arrangements in place, it's going to affect your ability to move forward into the future, and also to attract new GPs into your property, into your practice. Again, there are issues with high costs being demanded. You're losing control where you're a tenant. Very often we see numerous partnership disputes linked to premises issues where perhaps there aren't the right provisions in the partnership agreement relating to how you deal with property when a partner leaves and a partner joins. CQC have now started to scrutinise property in more detail, and therefore if a property isn't fit for purpose, that can have a real impact on CQC rating, which then obviously has an impact on, can have an impact on the viability of the practice. And very often we see property as being a barrier to working at scale, looking at mergers, primary care networks. If you can't align all the property interests going through into a merger arrangement, that can perhaps be a reason for the merger to fail. It's not all doom and gloom. There are always around it. So before I get into the substance of the review, here are a few quotes and concerns you may be able to relate to. The BMA survey in February 2019, 80% of 1,000 practices interviewed said their premises would not be fit for the future, and 50 said they were not currently fit. GPC feel that too many practices are coping with inadequate facilities, bursting at the seams, no support to expand. And this is all in the context of the Naylor report, really saying the way forward is to move into bigger hubs and to better premises. The question is how. Increasing numbers of doctors don't want to risk long-term leases or property ownership. Really, really needs to be addressed to be able to develop PCNs and community services, especially where, and you'll see this when we come on to the policy review, it looks like a lot of funding is going to come through the primary care networks who are operating cohesively and have got an estate strategy. Dr. Nigel Watson, the author of the review, very strongly feels the premises cost directions which set out how property is reimbursed through NHS England to GPs really don't fit with the way we work today and need to in the future. A number of you may know that you can only get 66% of funding for capital improvements, for example. It's really essential they enable integrated working. So for that to happen, they need to change. Watch this space. The change has been coming for a while. Spending review, disappointingly, whether because it's the government is distracted elsewhere, does not contain the detail of the specific commitment expected, perhaps to allow there to be a bit more clarity and comfort that things will now be able to be implemented as recommended by the review. So the key issues explored by the review, which I encourage you to read, it's quite a simple document to read, it's not too long, are the following. Issues with leases, issues with outright ownership, the idea of perhaps looking in more detail how you can separate estate ownership from the contractor. So new GPs joining your practice can contract, but they don't have to get involved in estate ownership. Looking very closely at estate strategy and planning, how important that is for practices to be able to sort of work out how they're going to best use their estate. More scrutiny around uniformity of quality and maintenance standards, and issues around funding for capital redevelopments and the premises cost directions. And that would be either looking at things like a practice developing its own property or perhaps looking at third-party developments where another party develops and the GPs take a lease back. So the first one, I think this is what a key one, there's a lot of focus on this. Last man standing, what does that mean? Well, that means basically the fear that you could be the last GP signed up to a lease, you want to retire, nobody else will join the practice and take your lease over. You want to hand back your contract. As soon as you hand back your contract, you lose your rent reimbursement from NHS England. And that basically means that if you do retire, you're still going to be liable for the full cost of the lease. It's a scary proposition. It's a scary situation. And it's putting off a lot of GPs from signing leases. Not all GPs though, because if you're in a very relatively youthful practice where it's a strategically important area where you feel the practice is very viable, you probably don't have any concerns about retirement and going forward with your current partners. But if, again, the demographic means that a lot of people are thinking about retiring and you think there might be some challenges for your practice in that area, you may be quite worried about that. So there's the last man standing, there's concern over liabilities and length of leases for existing premises and new builds, signing up maybe for 15, 20 years. If you want to do a sale and lease back, do you feel comfortable about doing that? It might be the only way you can get a new build if you do a third party development, if you can't get funding for your own. A lack of certainty of funding around unknown lease costs. So you might be moving into shiny new building and taking a lease back. You can't get a cap on the service charge. Not all of the funding from NHS England may cover service charge costs. And again, those could change quite drastically over a long lease length, and that will be a cost to the practice. So what does the review say? The outcome it recommends is that leases should be transferred to the NHS. There should be the ability to transfer leases to the NHS or other appropriate bodies where a lease prevents the healthy renewal of partnership and the estate is of strategic importance. Well, what does this mean? So the healthy renewal of a partnership will be something around, the practice not being able to move forward because of the lease issues. What does strategic importance mean? It's not quite clear. And again, this is a wording that a lot of kind of analysis of this, that's going to be wide open to interpretation. Certainly, it looks like the property must have ongoing importance for the delivery of primary care services. And that should be very closely linked to the STP ICS estate strategy. And that's why it's really important to develop this, because if you're shown to develop that and showed to be aligned, then that's going to help you if you need any support from NHS England relating to your estate. It's very much seen a move of last resort. It would be at the NHS England's request, and the appropriate entities to take over the lease would be NHS Foundation Trusts, local authorities, or NHS Property Services. They can't be forced to step in, so it does assume a willing host to take on that responsibility. What then would happen, the idea is, there's still a lot of detail to be thought through, the practice would then take on a shorter form of sublease. It would mirror the head lease granted to that entity. Now, there will be additional professional and tax costs for a sublease, for example, stamp duty, land tax and professional costs. So if you've already incurred those on your main lease, again, that's another cost that might not be reimbursed. If NHS Property Services is taking over the lease, then there could be some additional management fees that won't be reimbursed. I think there's some trust issues with potential landlords, I think particularly around NHS Property Services, who have been seen by many GPs to be fairly aggressive in their programme of GP regularisation. So I think there's a bit of work to be done on the softer issues around that. And will it make disputes and enforcement more complicated? Because again, if you've got a head landlord and then an ultimate freeholder, there could be some issues around too many cooks spoiling the broth. But again, there could be some positives that come out of this. But is it a solution? Well, it's not clear what strategic importance means. Is the test likely to create issues and uncertainty? Could it create two tiers? So if you apply to have somebody take your lease over and you're told that your property isn't of strategic importance, that's potentially going to be of impact on value. So you could end up with two tiers of primary care property, those strategically important and those not. There are dangers of creating a split and then increasing issues with the recruitment. Who wants to join a practice that isn't seen as strategically important? And actually, do those who have strategic importance under this test actually have an issue that needs to be addressed? Because they're likely not to have issues with new partners joining, and they're likely already to be a practice that NHS England would otherwise save. So the fear is there could be some cherry picking of stronger practices who don't actually need help. There could be additional costs and risks, professional and tax. I think Foundation Trusts are going to have issues with the accounting provision under CDL, and the spending review hasn't really given much hopeful clarity around how that could be adjusted to enable them to engage in the primary care sector. So still more detail to follow, but one to watch. It could be a solution in some situations. The second is, what about ownership? If you look at Scotland, there is now a plan that primary care will be moved into state ownership over the next few years, or maybe decade or so, but there is a medium-term plan. So the idea here would be a state buyout and some form of state-backed loans, but this has been rejected, clearly rejected. There is still a perceived desire for ownership and flexibility, and that did come out of the partnership review. Some partners still want to operate how they're operating and feel the partnership model works for them. So there needs to be a choice, and a state buyout would not give that choice. It's also seen as cost prohibitive based on the likely benefits. And what the government is arguing is that the comparison with Scotland is not like for like, because there are other issues that are have changed in Scotland around how the contract is put together, which have not been replicated in this country. So no hope on state ownership at this stage. What about property in the partnership model? What did it say about that? As I've mentioned, it's still desired by some, and in some cases it's definitely the right thing. And historically, I think some practices have done very well out of property ownership where they've had the costs funded by NHS England. but in some cases it is a problem, last man standing and negative equity. So how about separating the decision to contract to provide services from premises ownership? Well, what the review says is we'll look at that more closely. We'll think about this more and how that could work. But that one of the key messages is that any practice that wants to look at that working for them when it becomes clearer will need to show robust governance where the NHS do decide to fund ownership and show a clear understanding of risks and liabilities. So I think the message we're saying to practices is never has it been more important to make sure your housekeeping is up to date, show that you've got up-to-date partnership agreements with the right property provisions, that the title to your property is vested in the current contractor's names, you've got evidence you've had professional advice, you've got buy-in by all your partners to what's happening with the property. And I think then you will feel you're in the strongest position you can be in. If you do need to go to the NHS and ask for some support, you're more likely to get it. But what they're saying is you can't assume that you will be entitled as of right to further support from NHS England for new ideas. So on this particular topic, best practice guidance is to follow. Estate strategy and planning. So there is definitely a lack of a clear national picture around primary care. The STPs and the ICSs have been tasked to develop estate plans, but we've not really seen a huge amount come out of them. The review says there will be a package of support for primary care linked to the engagement of primary care networks in these plans. So again, put yourself in a strong position. If you can work through your own property requirements, think about your own PCN strategy and then start to engage at the STP ICS level, you're going again to be positioning yourselves in the best place. And it's a big challenge because you've got so many other demands on your time. There is so much data that is not clear to inform any estate strategies. The NHS Property Board is putting together a data collection project, but there is a lot of work to be done. There are barriers to capital funding through premises cost directions and the release of monies from the ETTF. And I think practices need access to support and expertise to be able to develop these plans. And there are clear roles really within the local system for there to be a lot of training and guidance. And there is a resilience fund that NHS England are making available. I think there'll be support through your CCGs and your LMCs. So I think it's important that you knock on their door and say, can you help? We want to do this. Can you help us do it? So there's a lot of continued work around this, but I think it's going to move from just being at a talking level to actually being something that people really, really do need to engage in. But you will need support to do that. And there are people out there who will help, professionals who are looking at giving really valuable support around this issue. Quality and maintenance. The review wants to see very clear standards for property ownership and management. It wants clarity and consistency for both owners and occupiers. So if you own your practice, if you want to carry on getting your notional rent or your borrowing cost rent, we want to see that you've complied with these quality and maintenance standards. If you're an occupier, you want clarity to know that your landlord is aware of these and will comply, because this is going to be also picked up by the CQC. So the guidance is to set out roles and responsibilities for owners and tenants linked to PCD reimbursement. So it's not a nice message, perhaps, that the review is sending out, but it's basically saying if you want to carry on getting reimbursement through the premises cost directions, you're going to have extra responsibility and there's going to be extra work to do. And the idea is for there to be a form of customer charter around what should be expected of primary care property. And then finally, just on this very, very kind of brief overview of the key themes of the review, what about new models and the premises cost directions? Premises cost directions do not currently facilitate new models that are practices and networks are being asked to put forward, new hubs. To move into a new hub, you need to access funding, or you need engagement that the NHS England will meet the higher rents that a third-party developer will charge. And there are currently a cap of 66% on the amount you can get through the premises cost direction. So unless you're fortunate enough to have equity in the partnership, or you can get funding from a bank. You may struggle to do a new development. So the review is saying, well, perhaps we'll start looking at network level reimbursements. So in some cases, they say that they're going to look at pilots where the NHS bears the cost of multi-use new builds. As I said, the criticism of the premises cost directions is that they hamper reform and they don't fit with the new integrated ways of working. So there are issues with incentivising cost management, facilitating hosted premises, and the time-consuming reimbursement processes. So the NHS is looking really at running some pilots where they will bear the cost of new builds, but also a solution around a single payment approach where NHS will bear the property costs, the reimbursable costs, and the practices will just pick up the non-reimbursable costs. Now, this idea of a single payment approach is not supported for immediate implementation, but there is a recognition that things have to change because of the premises cost directions not being fit for purpose. So these network level arrangements will be a limited pilot to test a single payment model of reimbursement. The NHS will own the asset and it will meet the cost of the hubs directly. And as I said, the practices will meet the non-reimbursable costs. There will be a license to occupy between the practice and any other providers, but it's very headline at the moment and it needs significant development and piloting. But do watch this space, and I think networks who are in a strong position, who've got a good estate strategy, will be in a better position to have access to anything that comes out of this pilot, or even be part of the pilot. Really worth talking to your CCGs and your STPs around what they're doing in this area. So what's next? An implementation framework to be informed by the spending review timetable and outcome, and disappointing that there wasn't a huge amount of detail. So I think it really is watch this space. There's a lot more detail to consider, but what can you do that's within your control? I think number one, be aware of the policy review, talk to your CCG, think about your own practices property, think about your own networks property, get things in order, really encourage your network to start working out their future estate needs, taking into account joint working, talk to your STPs, inform yourself, and just, you know, watch the space really. Changes are afoot, and I think that more and more premises funding is now going to start to come through at network level. And so the stronger you are as a network, the better position you're going to be in. And I think, you know, there should be some more scrutiny now around the spending review and how that's going to facilitate what the next step is, which is the publication of a premises implementation framework. So there is a lot in there, and there is a lot for you to think about and do. And this webinar is really just to give practices a flavour. I mean, we could have run a sort of morning workshop on current property issues and the implications of the review. But I hope that's been helpful, as giving you some pointers, and my contact details and the contact details of Kieran at Primary Care Direct are on the slide. And, you know, as I say, we're very, very happy to pick up any questions that you've got about your own particular requirements or anything around a bit more detail on the premises review. So Damien, I'm not sure have we got much time now to pick up any questions? Ooh. So I'm going to have a look and see. Will the slides be available after the webinar? That's a question that I'm able to pick up. Yes, I believe so.
Hi, Lisa. Sorry, I was on mute there for a second.
No, that's fine. I've just picked up one question from the Q&A, which is, will the slides be available after the webinar? And the answer is yes, I believe.
Okay. Well, my suggestion also is I'm going to leave the webinar open for 10 minutes, which will leave the Q&A facility open for 10 minutes. If any have any questions, feel free to leave them there, and what we'll do is we'll collate them and look to put together a review sheet depending what those questions are, if that works for everybody. We have everybody's contact details, and to let you know, the webinar will be available on Primary Care Direct's website. I will send out a link to that to all attendees in the next day or two as well. Okay, so that's 2:30. Do you have anything else to add, Lisa?
No, nothing other than say thank you very much, and you know, very, very happy to deal with any further queries, and all the best of luck for all of you in sort of facing your property challenges.
Yeah,
thank you.
Thanks very much, Lisa, and thank you everybody for joining. Like I said, I'll leave it open for 5 minutes. Bye.